So we're going to talk about some work we've been doing for decades now, actually, treating brain diseases with electricity. Not a lot, but a little bit of electricity in the right spot. So one of the problems that I face as a neurologist, I do things called movement disorders. So things like Parkinson's disease, people with dystonia and tremor, and they shake a lot. And this is an example of a patient with Parkinson's disease. They're usually older, 60s and 70s. And this is not advancing. You want to try to advance me? Oh, did it go? Okay. So it affects about 1.5 million Americans, well over $25 million a year in cost. The symptoms they have are they're slow, they're very slow, they're stiff, the muscles are stiff, they can shake, they have a tremor like this. It's called a pill rolling tremor, because you're rolling your hand like you're rolling a pill. And that's usually at rest, and when they hold their hand out, it goes away, and then it starts to come back again. They have some gait and balance problems, so they can be very slow and very stiff, and they can fall. So that's Parkinson's disease. That's what we call a basal ganglia disorder. In others, you have two sets of basal ganglia deep in your brain. These are structures that help to control movement, but are also involved in your moods, and they're also involved in your intelligence, memory, concentration, those abilities. But different parts of the basal ganglia do different things. And this part of the basal ganglia that controls movement is malfunctioning in Parkinson's, because you're losing a chemical called dopamine. A part of your brain makes dopamine and sends it to the basal ganglia. It helps it to function. You don't get it, you get Parkinson's disease. That's what it looks like. Now, another basal ganglia disorder that's very different from Parkinson's disease, but again affects the basal ganglia, is something called dystonia. This is a kid with dystonia. And what he has are involuntary movements he just can't control. When they first start, sometimes they can only occur with certain movements, but over time they can start to involve pretty much any movement, and then can occur just even at rest when you're sitting still. What I've had people tell me, I want to cut my arm off because they can't control their arm. And it's doing this all the time. Kids come into my office, they're sitting on their hand. And why are they sitting on it? So it doesn't move, because they can't help it. And this affects probably, maybe a little delay here, I think, eh? There we go. 300,000 Americans, probably more like 500,000 just in the US and North America alone. There's over 20 forms of this. We're finding genes every day that deal with dystonia. It's a very difficult condition. Can you imagine being a kid like that and trying to go to school? You know what peer pressure is like? How kids feel? If you wear a different shirt, your kids are looking at you, let alone if you can't move or you're walking like that. Difficult disorder. So how do we approach this problem? You know, we've got these major neurological disorders we're trying to deal with. How are we going to address them? Well, scientific method, right? We have to develop an hypothesis on what's wrong, develop a method to study it, and then find things that support or refute that hypothesis. That gives us an idea of what might be wrong. We have to ask ourselves these questions. One, is it at a molecular level, something inside the cell that's just not working right, so the cells don't work right? Is it cell to cell, or is it some big system, a circuit? In your brain, you have multiple circuits. They start at a certain part of your superficial level, the cortex, and it goes down to a deep structure in the brain, which goes to another deep structure in the brain, goes back up to the surface of your brain again, and that's a circuit. And oftentimes, if it starts, let's say, in the movement part, like the motor cortex, it goes to a movement part in the basal ganglia, and goes to a movement part in a place called the thalamus, and back up to that same place it started from in the motor cortex. So it's a circuit. So we do things called circuit analysis. What's wrong in a circuit? If you have a circuit dealing with movement, you might get Parkinson's disease. You have a circuit dealing with mood, you might get depression. Another circuit might give you schizophrenia. So these are circuit disorders. We have to understand what's wrong in those circuit disorders. So what's the effect of the changes? Once we can understand that, how does that change brain activity? What happens? And then you have to say, how do we fix it? Can we repair it? Can we replace it? Or can we modulate the change that occurred to move it back more towards a normal level? And we're going to talk about modulating the change. And that's how we use electricity. Very small amounts of electricity to modulate brain cells. So what is it? Well, it's an intervention where we take small amounts of electricity and modulate brain cells, which affect actually that circuit we're talking about, infect multiple circuits. You can do light, electricity, ultrasound, and even magnets people are using. You can do it at different levels. It's the cortex, the surface, deep brain structures, which we do. You can do it at a spinal cord level, if it ever moves. It's amazing, we can put DBS devices in the brain, but I can't make my computer move, right? Spinal cord stimulation, peripheral nerve stimulation, and it's something called the autonomic nervous system. It controls your heart rate, controls your gut, controls your breathing. These are all automatic things. Now, patients with Parkinson's disease lose all the automatic movements. Eye blinking, facial expression. One of the most common things I hear spouses say is he or she, they're always mad at me because their face is blank and they think they're angry. They're not. They're just a masked face. So what are the advantages of using electricity like this? Well, one is it's adjustable, it's non-destructive, and it's reversible. So if I get a side effect, when I put a pacemaker in your brain and I get a side effect from turning on the stimulation, I can adjust the stimulation. I have the option to take it out, which I'd rather not do, but if I don't have a good location in your brain, I can take it out and we can reposition it and put it back in again. The key to success in deep brain stimulation, it's like real estate. It's location, location, location. And if you're off by a millimeter, and remember there's 25 millimeters per inch, 1 silly millimeter makes a huge difference in your benefit. It'll change your outcome. So, deep brain stimulation, that's the definition. This is a lead. Now, this is not to scale, by the way. You can imagine what that would do to you if I put that in your brain. But this is 1.27 millimeters in diameter. This contact is 1.5 millimeters, and there's 4 of them on this one device that's made by Medtronic. That lead is then implanted through a hole that's in the skull down deep into these deep brain structures. Now I'm going to tell you that one of the deep brain structures we put it in is the size of a pea, 5 millimeters top to bottom, 0.2 of an inch. And again, this is 1.3 millimeters. So you have to be where you need to be for this to work right. All right, so this is a DBS device. It's implanted. And you can see these are pacemakers that generate the current that go through an extender wire that connects to a lead that's then implanted in the brain. And what we believe happens, and I've been studying this thing for probably 15 years, how it works. It delivers pulses to these structures, but it alters the disruptive brain signals. That was at Emory, by the way. You can go ahead and the next slide. Yeah. I'm trying to move. There we go. Yeah, you don't want to look at that. That was when I had hair. And it was actually dark, wasn't gray. Let's hit this one too. There should be a start. This is a woman who had deep brain stimulation, one of the first ones that we had when I was at Emory University.
For teaching us to survive this day, and really there.
For Sybil and Alvin Guthrie, these were supposed to be the golden years. After moving to the U.S. from their native Jamaica 22 years ago, the Guthries had found the American dream. Good job. She was a nurse and he was a civil servant. And a great family. Now it was time for the fun stuff. But almost a decade ago, Sybil noticed a tremor in her right arm.
I noticed when I raised my right to put my makeup on, it just, my arm got really weak and it started just trembling.
A doctor confirmed her fears. 52-year-old Sybil Guthrie had Parkinson's disease.
For quite a few years, she was able to function very, very well. And then it kind of got scary then, because even with the medicine, then you could still see that this disease was really progressing.
By the time we met Sybil this past spring, even a simple task like eating breakfast was a frustrating battle with her own body. The disease had gotten so bad that sometimes her muscles froze completely, making her face almost expressionless, and her legs almost useless. The woman who once was always on the go could barely move, confined to a wheelchair. There is no cure for Parkinson's disease, and often it only gets worse with time. But Sybil never gave up hope that someday doctors would find a way to restore her functioning and her life. She put her name on a list at Emory Medical Center near her home in Atlanta for a radical brain surgery. Here's how it works. Dopamine is a key chemical messenger that keeps certain parts of the brain under control. With Parkinson's disease, decayed brain cells fail to produce dopamine. As a result, Those brain areas fire wildly, making muscles throughout the body either shaky or rigid. With deep brain stimulation, a tiny electrode inserted into the brain emits an electrical current that brings those brain areas back under control so muscles return to normal. The electrode is powered by a pacemaker-like device in the patient's chest. Her doctors hoped surgery would correct the tremor and freezing on Sybil's right side. They knew that symptoms on her left side wouldn't change at all, but they hoped there might be enough overall benefit so she could walk again. Although the doctors weren't sure what the results might be, Sybil had high hopes for the surgery. And during the long hours while surgeons probed her brain, she had only one thing on her mind: walking.
And when it's all over, I'll be getting up and walking. That's what I was really thinking about. I didn't think anything negative. Everything was positive.
6 weeks after the operation, the changes on her right side were even more dramatic.
So this is after one lead was put in on one side of the brain. And even now, she's walking pretty well.
Able to get up from a chair by herself. After surgery, it was no problem.
It's after the second side.
I feel as if I've been given my life back. And I'm taking home.
And I can tell you that never gets old. It never gets old. And you know, this was Dateline. We had no idea. They wouldn't let me see the video. So I was taking phone calls like at 9:30, 9:45 when it was going to air at 10 o'clock. My wife and I was telling my wife, I said, my God, they're calling me. There's only 10 minutes for the show's on. And I had no idea she could run up the hill. I found out later, but I had no idea. So I'm going to show you now a patient we did at the University of Minnesota recently. So this is a side-by-side version you get a chance to see. This is before surgery, and here he is after surgery. And you can see the spontaneous movements he makes now. He's smiling, things you don't see. You can see the masked faces here, lack of associated movements, going up the stairs. And I think there's a longer video to this, but I don't want to take all the time to show that. But it gives the family perspective. Remember, it's not just the patient. It's the whole family that's affected by this. He's done extremely well. And then we move on to the next one. Now, what about this kid? What can we do for a kid like that? I want to show you a video now of a guy who's older, who developed dystonia when he was in law school, and then eventually finished law school but couldn't practice. So this is a guy named Peter Cohen. There's no HIPAA with Peter because Peter doesn't care. Peter wants to talk about dystonia, what it means. Here he is before surgery. Again, he's got generalized dystonia. So when you try to make a movement, you orchestrate. It's like an orchestra playing. Some muscles contract, some muscles don't contract. You suppress some and activate others. With dystonia, they can't control that. We call it overflow. If I go to move my arm, my neck and my back and my other arm might pull. And you can see with Peter, but here he is after DBS. He's on a treadmill. So you saw what he was like before, and that's what he's like now. And there are two people that actually, patients have my cell number. He's one of them. And I'll tell you why in a second. We're going to do the next one. Actually, it shows you Peter now traveling, Eiffel Tower, got married, he's back to work. So you really can, for dystonia particularly, it's not a progressive degenerative disease, whereas Parkinson's is. This is not. And these folks have done well from the time they've been implanted, as long as we get a good location, to present time. I'm going to show you a kid. There we go. So this is a little boy with dystonia. He's got generalized dystonia. And this is Chris. And you can see his hand is pulled. See how his foot's turned in down here? See how his back pulls back a little bit? And his arm is still pulled. He tries to take the left hand and move the right arm. I want you to know something else. Look at how he smiles. He's always smiling. See how that one pulls back? His head pulls forward. His foot turns in. And he's still smiling. So I'm going to show you a picture in a second of Chris a couple years later. But I want you to see what it's like for him to try to walk, how difficult it is. And you'll see that in a second. See how his back pulls him back again? Here he's trying to walk. Like, can you imagine other kids are out playing ball or even just sitting straight in their chair at school? What he has to go through? But they don't fall. His dad says, now he'll run back. Come on, run. That's his running. But look at he's smiling. Yeah, this is a great kid. So can we start the left video? This is Chris about 2-3 years later. He's now almost immobile from dystonia. He can't move. He's in a wheelchair. Can you start this one right beside it now? Here he is after deep brain stimulation. Now you notice he's running, but that arm was a little tight on that left side. But he's doing a lot better. Now I'm going to show you a picture about 4 years later. And this one might start on its own. Oh, you have to start it, I guess. And here he is, and you can look at this hand. It's just a short video. It's pretty straight, much better. Now, why is that important to know? Well, I'll tell you, because we first did our first case of dystonia back in the 90s. We implanted this kid in Parkinson's disease, and I'll show you a video of that. In the operating room, when I turn on the stimulator, they get better if I'm in the right location. If I'm not, I'm more inclined to want to take it out and try to reposition it, which is not easy to do. That's very hard to do. With dystonia, we did our first case fully expecting we'd get immediate benefit as soon as we put the lead in and we turn it on, and nothing happened in the OR. Nothing. And we got a little concerned, but we had such a good location, and I'll tell you how we do that. We felt very confident in the location. We decided to leave it in, and we put him back in the hospital room, and we turned it on the next day again, and still nothing happened. Now, you have to imagine, you get relationships with these patients. I don't subscribe to the argument that you can't get connected to your patients. I subscribe to the argument that you have to be connected to your patients. Your patients have to know that you care about their health. They can't just think you're there for a job, in my opinion. So I got to know Dana and Gus really well, Bill's parents, the first patient we did. And I remember when we turned on the stimulator and nothing happened, you could feel that room, right, drop down in energy about 1,000 points. And I kept turning up the voltage, trying to get a better benefit. Now, if you get too high, you run into side effects. In fact, if you get too high, if your current density is too high, you can lesion the brain. And so on this old device, it said, warning, tissue damage may occur. Didn't want me to program it. So I talked to the patients, talked to the family, and said, I think if we do make a lesion here, I think it'll be okay. And they agreed. So I put clear, enter. Nothing happened. So we sent them home to the hotel and said, call me and if anything changes, otherwise you guys can go home and we'll see how things go. I was rounding at the county hospital, which is Grady Hospital in Atlanta at the time. And I don't know if there are any physicians here, but I don't think any physician would ever tell you they got a phone call with good news, right? Because I'm sitting here at the residence rounding in the morning, and I got this page from Dana. She wanted me to call her. And I thought, oh, what happened? I got her on the phone, and she said, Jerry, you won't believe it, because we're on a first-name basis by now. She said, Bill's back is straight. I said, oh, my God, Dana. She said, it's just straightened up in the last couple hours. And then eventually we got his neck straight. So what we found out with that was that there's a delay. Hours to days and sometimes weeks, and it took me a year to program one patient. And why is that important? Well, at a meeting when I presented this data at the American Academy of Neurology, one of the guys from France came up to me, and he said, Pierre Pollock, and he said, Jerry, I wish we'd known about this. And I said, why, Pierre? He goes, because we put one in a kid with dystonia, we turned it on, it didn't work, and we took it out. So now we know. But those are the lessons you learn, and you've got to be open to seeing some of these things. I mean, you can't get so wedded with your hypotheses, right, that you're not willing to change them. That's the biggest thing. So, let's see, is this going to go in? I'm having trouble with this. There you go. This is a quote from one of the parents, and this is a guy's a pediatrician. This kid had generalized dystonia. And again, he said, I want to update you on so-and-so's progress, almost back to normal, running, riding a bike with training wheels off all the meds, sleeping without discomfort, spine is straight. Thank you so much for helping so-and-so. And I keep all these, by the way. I have a desk full of them. because there's nothing like it. And whenever I get a really bad score on a grant, I'm not going to get it funded, I go back in my desk and I read all these things, right? Because you're going to keep going back, right? That's what you do. So this is an inherited tremor. She can't control it. It's about 8 to 12 hertz, 8 to 12 cycles per second. It usually involves the hands, it can involve the head. If you remember on Golden Pond, Katharine Hepburn, she had essential tremor. That was a voice tremor she had. This is after stimulating a place called the thalamus. We're doing the left brain for the right hand, and you can see it's absolutely calm. We didn't stimulate the right brain for the left hand, and that's still affected. She's smiling because she said, I haven't had my hand still for over 10 years. What you're going to see in a second is we did the second side, and she's in the hospital, and we're going to turn on the stimulator. That's going to be the follow-up video here. But now you can see drinking from a cup. These folks have a lot of trouble putting on makeup, putting on glasses, shaving, turning on the stimulator, and immediate effect on the tremor. And that's what we're used to seeing. The dystonia was an unusual case which really threw us off initially. Okay, try to move it forward. There we go. So I was just at a big meeting for Abbott, who's now also in the business with these leads, giving a lecture on DBS and where I thought it's going. And actually, I like the quote that one of their marketing managers said. It's a remarkable therapy, just getting started what we can do in this space, and I couldn't agree more. This is another thing we need to look at. This is where we are. We actually have Parkinson's and tremor that's FDA approved, dystonia and OCD as a humanitarian device exemption. All that means is no FDA study, but the data is overwhelming, so they're allowing us to do it. These other things, depression, the tics and Tourette, cluster headaches, pain, epilepsy, stroke, addiction, they're all being studied right now. Other things we think we can go to, potentially schizophrenia, Alzheimer's, the list goes on. In fact, there's one example of a patient with epilepsy where they have a grid in and they're monitoring the neural activity in this patient, and they're stimulating in a certain place, and that patient was able to learn and perform motor acts quicker than when you didn't stimulate. So there are other things that you can do with DBS. Yeah, go to the next one. There you go. All right, what about depression? Can we do something for depression? This is a patient with depression. It's very common. Here's another picture of a patient with depression. Now you know how that's got to feel. These are people that have been on maybe 3 medications, nothing works, electroconvulsive therapy doesn't work. So the next thing I'm going to show you is a patient we did at the Cleveland Clinic in the operating room. We have a lead in place, we're turning it on and asking her questions. How do you feel? So we'll go with the next one. There we go. And you may have to turn the volume up a little bit on that one. There you go. So now this number here, that's the voltage. She's feeling better.
A little better.
What do you feel?
6 volts.
Happy?
I like to smile. Do you want to smile? I haven't smiled for a long time.
7 volts.
What do you feel like now?
I feel pretty good.
Where would your mood be now? 7 was before.
Yeah, well,
About the same.
I feel pretty good.
Got laughing, huh?
What are you thinking of right now? What are you laughing for?
Yeah, I feel so good right now.
And then we turn it off and watch her face.
I don't feel like before.
Where's your mood at right now?
I don't think it's that bad.
Turn it back on again.
What are you feeling, Karen?
It's almost like you've got strings and a puppet, right? And you can pull the string. Now, you're going to be surprised when I tell you that 2 big clinical trials done for DBS for depression failed. They both failed. And I want to go back to what I told you earlier. They did 20 sites. They were not ready for the study, in my opinion. But you have to also look at what this potential means to companies in the market. Depression is a huge market. People want to get in, they want to be first. The trials weren't ready. And remember what I said about location? If you look at where leads were placed, there's probably a variety of places that these leads were placed. They're supposed to go in one spot, but they're all over the place. That's probably why it failed. So we're not done with this yet. You can see it can work. Of 7 patients done at the university, 4 people are completely back to work and doing well. So we're missing something in this. So I want to tell you now about how do we get there. Because I showed you all the good things, right? But I didn't show you all the hard times and what we had to do to get there. We had to figure out, and it's preceded anything I've done. We had to understand, how are these circuits organized? How are they connected? What connects to what? Then we had to understand, how do they work together? What's the physiology? How do they interact with one another? And then when you have a disease, what happens in the circuit when you have a disease? How does it change? And then once you know how it changed, is there a way we can change it back? Is there some mechanism we can use, like DBS, to get it back? This is what I think this is a perfect slide to tell you what it's like. To me, this is the research you have to do, the decades of work you do to get to the tip of the iceberg, so to speak, which is the patient care. And we're still diving into a lot of this work that's got to get done for us to figure out, why did that depression trial fail? Why can't we get the same benefit in every patient every time? Why is that? So this is where we started. You're gonna find this interesting, scary, if you lived in the 30s and 40s. This is a picture of your brain. You're looking from the front end. Here's the surface up top, going down through the brainstem and the spinal cord. And these little gray areas are places that people lesioned or took out. So this guy named Busey wanted to treat tremor. So what he did was he just extirpated or took out the motor cortex. It stopped tremor. It also stopped all movement. So that obviously wasn't the answer. Then they said, well, let's go down here. Let's make lesions in here. And they started making lesions in those structures. But remember I told you it's very precise, right? You know how they used to make these lesions? They used to take a look at the outer part of the eye, and then the ear here, the canthus of the ear. So that was a line. They'd make a hole in your skull, and they would eyeball it, looking at this line, front of your face, with a little probe that went in and destroyed tissue. Yeah, right. It's like, if you remember pithing a frog when you're in biology, it's a bit like that. 30% of the patients died. 40% had marked complications. They were much worse off. 30% either had no change or maybe some benefit. But that's where we started. I call that the lesion and look approach. Or frankly, it's more like, the next one, poke and hope. And the next slide shows you that. Yeah, next slide. So this is a good one. Bunch of surgeons standing over a table, poking the guy's brain, finally hit a spot, leg goes up. Whoa, Hobbs, that was a good one, right? That's kind of where things were. And that's not what you want if you're on that table and someone's going to do something to your brain. So this is a guy named Freeman. And I'm pointing this out because desperation leads to mistakes. And I can tell you many patients have come to us who didn't have Parkinson's disease but had a movement disorder we know is not going to respond to this, and they really almost beg you to do it. But you have to explain, I will make you worse. We can't do it. But in certain times, people did psychosurgery, and they were desperate. So they did these things called ice pick lobotomies. And what I would leave you with is that next slide is that those who are ignorant of history are destined to repeat it. If we don't learn from our mistakes, we're going to keep making them over and over again. And this next slide. Go ahead, one more. This next slide shows you how he did it. He's got an ice pick. He's got a hammer. He's going through the nose. And he's doing a lobotomy. So again, we need to learn from our mistakes. Next slide. So how do we solve these problems? You know, again, we talked about learning anatomy and physiology, et cetera. So we have to say, what's the target in your brain? What's the best place to go? You don't want me to do a crapshoot on this. You want me to know where I'm going and be precise about it. There was no rationale for that target. They had no idea where to go. It was just poke and hope, take a look and see if you can make a lesion that helps somebody. But people were desperate. If you have Parkinson's disease and you're rigid and stiff and you can't move, a lot of people would feel like that patient with dystonia whose arm is going all over, just take it off. Just do what you can. If I've got a chance, any chance is better than no chance. That's not always true, though. So we didn't understand the circuitry. How do we get to the target if we do understand the circuitry? And this is something you're all going to love at this point in the talk, I'm sure. Postprandial, and I show you that, right? I'm just trying to show you the connection. So this is the basal ganglia circuit. There's a surface of your brain. This is all basal ganglia stuff. And there's all these connections that go on back and forth. And we try to understand, how does that work in the normal condition? If you understand the normal, maybe you can understand something about the abnormal. But that was pretty hard. So something happened that we got lucky. Not lucky for these people, but we got lucky. These patients. These are what's called the frozen addicts. Anybody hear about the frozen addicts? Anybody in this room? What this is back in the 70s and 80s, people in California were taking designer drugs. So you could make a drug and just add a side chain of methylation or anything, and it was no longer illegal, it was legal. And what happened was, one of these patients showed up in the ER, and a neurologist named Bill Langston saw them and said, this looks like Parkinson's disease, but I don't understand. They're in their 20s, they shouldn't have Parkinson's disease. And what they eventually did is they figured out they'd taken this drug with an impurity in it called MPTP. It's a toxin. And that toxin, if you or I take that toxin, it'll kill the dopamine cells in our brain. It'll give us a Parkinson's disease. It'll give us a picture of Parkinson's. And so because of these patients and because they discovered the toxin that they had taken, there's a whole story with that, but I'm not going to go into the length of that one. If you want to hear about it, I can tell you after. But by getting that toxin, we are then able to use that toxin and develop a model. And it's an animal model of Parkinson's disease. So we were able to take this model. It replicates the human condition. The second thing is, it allows me to identify what changes occur and where in the brain. So when I monitor brain regions with the microelectrode, which allows me to monitor activity of a cell, I can tell you what the changes are. And I can tell you where those changes occurred in the brain. Then I have to understand how that works together from that big circuit I told you about. And then I have to understand how the devices that we implant in patients would work in these animals so I can understand how it works in a human. And if you have to understand that to be able to make it better. So again, I'm just showing you something that's going to make you block out, and I think probably want to go to sleep more than likely, but this is a normal. These are three different structures in the brain. Each of these lines is your cell being active. If you look at what happens in Parkinsonism, in an animal model, you can see lots of different changes here. And then we go back to these big circuits again, and this is what we did. We had to do these models and say, what do we think is wrong? And we've looked at this structure here called the subthalamic nucleus, and this structure called the globus pallidus. This means this was overactive. This is activating this structure. This is inhibitory. It suppresses this structure. And that was the argument that this is too active, this is also too active, and they have an effect that shuts down your cortex and gives you a Parkinson's picture. So then the logic was, well, let's make a lesion in the STN, this structure here, just take it out. That'll decrease its output, it'll decrease this one, and you ought to get better, right? So who's going to do this in the patients? Who wants to take the first step? There's always one that'll do it. So in the animal models, it works. People were afraid to lesion here, because if I lesion your subthalamic nucleus, you're going to be doing this. You're going to hemiballismus. Arm and leg will be flying all over the place. So people said, let's not do it there. Let's go ahead and do it right in here. And that's what people did, and that's what we did. Yeah, there you go. And this shows you, if you're looking from the top of the brain now, cut off the top, look down into the brain. This shows you front of the brain, the side, here's the skull. There's a little white matter that connects the sides of the brain. This is a place called the striatum, it's part of the basal ganglia. This is GPE, part of the basal ganglia. Here's your target right here. That big one, that gray one right there, and this is the lesion we made right here. If we lesioned up here, they would have thinking problems, cognitive problems. If we lesioned over here, their Parkinsons would get worse. So you can see the precision we're talking about. This distance from here to here is about 4 millimeters. So it's pretty precise. But I'm going to show you a video of a patient who had a lesion done and what happened to her. She's trying to tap her finger as fast as she can, and she can't do it. She's bradykinetic. Kinesia is movement, brady is slow, so she's bradykinetic. You can see how tough it is for her to walk. Her arms don't move. See how she's freezing, her foot sticking? Initiating movement is a problem for Parkinson's patients. And she's trying to turn. What you're going to see in a second is her after we made the lesion, and she's doing extremely well with this. That was back in '93 we did that. See how fast she is now? She's off her medications. And she's a real character. You'll see in a second what I mean. When we started doing that, we thought, well, if one side's good, let's do the other side. And we did that. And these are fresh lesions. You see the edema around the target site on both sides. So we probably did 600 of these lesion surgeries at Emory. Only 8 did we do bilateral. And why? Because they all got quiet speech, hypophonic. There was a Baptist preacher from the South that I saw. This guy had a booming voice. You could just hear him on the pulpit. And after his second side, which he needed, I had to lean forward in the exam room to hear him talk to me. He was so hypophonic. So that's the question then, why DBS? Well, why DBS? Because bilateral lesions, we had a problem. We couldn't do both sides. The other problem was if you made a lesion and you got in the wrong spot, it wasn't forgiving. You could get paralysis. You could get visual field cuts, impaired vision. You could have thinking problems. All those things, we couldn't reverse them. So we went into DBS. Next one. And we started putting a DBS lead in one side and lesion the other one on patients that had one-sided lesions. And then we went into actually doing bilateral DBS. I'm not going to show you that, but the bottom line is we started bilaterals because that's the advantage to the DBS world. One, I mentioned before, it's reversible. You can modify it, and you can do it on both sides. So this is now a more complicated circuit. So now here's the basal ganglia. Here's a place called the thalamus. Here's the cerebellum. Here's your brain stem. Here's the surface of your brain. That's all interconnected. And we first started looking at how does DBS work? What's the mechanism? What's it changing? This is what one of the folks said. You're never going to figure it out. Don't even try. But of course, that's not our MO, right? So we actually used an animal model where we used a scaled down version of the human. We put a stimulator in one site, and we were recording the activity in this site. Now, before I show you the data on this, I want to let you know that if you make a lesion or you stimulate, you get the same behavioral benefit. But if you make a lesion, you destroy tissue, so you decrease the activity. When you do stimulation, you do the same behavioral change, so everybody thought it should be decreasing the output, suppressing activity. And indeed, that is not what it does. All I'm trying to show you here is that this is without stimulation. This is during stimulation. This is how fast the cell is firing. It showed that rates actually went up. It also changed the pattern of the activity. I'm not going to go into all the details. We had to work out the details. We're still doing that. What I was trying to tell you earlier is that we all thought that these activity rates, when the rates go up, the rates go down, that's the big deal, right? But we had data early on, one more slide, and then we're going to skip to the end, is that this is a normal animal. Each of these dots is an action potential. This is a Parkinsonian animal. Yeah, the rates are up, but look at those patterns. Huge change. We knew this back in the 80s, but we kept working this old hypothesis. I'll leave you with this one, then one more, and that is that pride is concerned with who's right. Humility is concerned with what is right. So don't get so locked into your own hypotheses or whatever you're doing in school. Don't be afraid to challenge. Don't be afraid to be creative. I had a fellow come to me one time and show me some of our lab data, and it showed a certain change. I looked at that and thought, it's not a rate change, it can't be true. And now the biggest theory out there is the very change we saw that I ignored. And I don't think about that a lot.